first, I want to congratulate Saleh on doing a bunch of good things. And one of the most important things that he did when he started this system was to get some science and evidence base behind it. And that takes a lot of time and a lot of money. And I just want to, publicly thank him for putting some science behind a product, because we don't see that enough in our business. So I'm thrilled that he did that, and I thank him for that. And I thank you for being here. We're going to talk about why I use these burs. I'm an oral surgeon. I'm in Metairie, Louisiana, New Orleans. The Saints are playing Sunday at 2 o'clock Central Time. If you have nothing to do, please yell loud as you can. At home, they'll hear you. For those of you who are in Los Angeles, I'm sorry, but that's okay. All right. Yeah, go team, huh? All right, so why do we use these burs? So I'm an oral surgeon. I'm in the trenches. I'm in private practice. And so I've been doing implants for a long time. I know you hear a lot of people talk about that. Well, one of the things that I find that I like about these burs is it compacts porous bone. Now, I'm going to take a little different tack, as you've heard, but in general, that I like that compacting porous bone. It bends and it shapes bone without its removal, which I like, because if I have something that's set up and I don't want to remove the bone, I could bend it or move it around, and I don't take any bone out of the site. We use it. I use it a lot to finalize my sinus graft cases. I'm doing them almost all crestal. I very rarely do a lateral window for the last several years. And it shapes the implant site for immediate molars, and it doesn't remove interdental bone. So why am I compacting porous bone? So this is an old Calcitech implant. It's a cylinder. So when I started doing these in 1983, that's how old I am. This is an 85-year-old female, and I had one referral who would send me all of these 80-year-old women and men, and they had very porous bone. So the way I would place these implants, you see I navigated this, and I didn't do a sinus graft intentionally, by the way. I would drill a hole, and then I would put these graduating size osteotomes in and tap them. And I would say I'm tapping, but the patients are hearing, bang, bang as I'm doing it. And I'm compacting the bone, and I put the implant in without any removal. We had enormous success. So I've been compacting bone for a long time. And then we got away from all that. We got away from all that. So when I'm doing crestal sinus grafts, a couple of things. I want to eliminate the lateral window. There's a 10 to 15% perforation rate at the best. Some people say it's more than that. Smokers have a problem. I've seen all these people try to, heal the membrane when you perf it. And I think it's ridiculous because it doesn't work. So I like doing the crestal approach because it's less pain for the patient, less chair time, you get similar results, and less chance for complications. I'm in private practice, and I really can't afford too many complications. I take care of other people's, which is fine, but I don't want to create my own. So over the years, I've trying to look for alternatives to the lateral window. The first thing I like to do is the primary goal when replacing implants on any system in any way is you want to accurately and precisely place it. You want to make sure that everything is put in just the right spot. So I navigate everything. And one of the reasons I navigate the implants, and I use a dynamic system or static guide, is purulence. I don't know how many of you are familiar with this, but if you look around a curve, right eye, left eye, you see different things. And I'm lefty, so the right side for me is the purulence problem. And if I just use my eyeball, use the eyeball technique to put implants in, you know what that means. You look, say it looks about right, and you drill a hole. Sometimes with the purulence, I may be off a little bit. So you really got to get perpendicular to where you want to work. And the restorative space will also appear different with purulence. So this is the reason to navigate, is it eliminates that potential problem. And this is true for everybody. Some people say they can tell if you're left or right-handed by how your implants are tilted in the anterior mandible. And this really is true. So purulence is a point. So I'm navigating everything. Now, when the data that we have for dynamic navigation, we've published a couple of different places. This is referencing the first one we did in JOMI, and now we've done another one in JOMS. But freehand approach, if we look at 20 patients that had CT scans, a plan, but they were put freehand, Deviations are about 8 degrees off. And when we use the dynamic system or a static guide, you're in the 3 degrees off range. And that's significant. So that, and it goes on and on. When we look at other systems, you'll see the same thing. So I'm a big believer in navigation to increase our ability to place implants. Now, many people can put an implant in and have it perfectly positioned. But on an average, most people are about 8 degrees off, perfect. Now, that's a lot. Now, for the restorative colleagues, this is what happens. It's the surgeons say, all of my implants are restorable. You ever hear that? And the restorative people just smile and cackle because they go, yeah, but do you know what we have to do? So this is important. I do this every case all day long, every time. Every case that comes in, I navigate. And you can see I've just got a couple of the cases here that I've done, and it just goes on and on. So when I look at the data, so I thought when someone said, how many cases have you navigated since February of 2015? I said, 1,000. But actually, it's about 500. It's delusions of grandeur. I'm 5'6", so you got to take it for granted. But when I compiled some data, now we're going to recompile this in February, which is my 3-year anniversary of using the systems. We're going to have, and I got an IRB exempt so I can do it legitimately. There's a couple interesting things that come out of this database. Where am I really using navigation and what am I doing with it? And so when we look at 714 implants, we had 8 failures. And that's hard data. So I thought that was pretty good. In fact, I thought it was almost too good. I've had a couple of failures since, so we're probably up to 11. But interestingly, I thought I was doing a lot of immediate molar placements in the mandible. I thought I did a lot. Well, it turns out I did. Out of the 116 first molars, only 14 were immediate placement, which is interesting. That's because I'm not going to do it if I have lost buccal bone. I'm not going to do it if I have gingival recession. If there's purulence, I'm not going to do it. If there's a lot of osteolysis or apical lesions, I'm not going to do it immediate. I'm going to stage it. I'm going to graft it, and I use allograft in the sites. I don't use a lot of other stuff. But this is really interesting. This is where I get into the sinus thing. Is when I look at my maxillary molars and premolar sites, when I look at how many did I take the tooth out and immediately place an implant, it was 8% of the time, 8%. I thought that was interesting. I thought I was doing it more often. But the most interesting part is when I placed an implant in the molar sites or premolars, 44% of them had an immediate sinus elevation, 44%. And that's hard data. Now, that made me think, well, why? So I'm always want to put a 9 millimeter in, and now I'm doing 10.5s as my low end or 10s. I don't want to put something, I'm not using 6s or 5s in the maxilla because I pop it up and I just put the implant in. And I'm going to show you kind of what I do. And the Versah drills play a role in that. This is why I'm getting to this thing. So when I look at these, I look at several different cases. If I'm going to take a molar out, I either put the implant right in or I raise the furcation up. I cut with the piezo, the little tips they have. I think it's an OT5 or something like that, or 7, I don't know. But it's got the serrated edges, and I cut between the roots, between the buccal roots and to the palatal root, isolate the furcation, tap, 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 up it goes, and then I put the graft in. I do that routinely, and I'm going to show you those cases. Or I'll put the implant at the same time. On the edentulous sites, I'm going to bump it a lot when I do this through the surgery, or I'm going to do maybe an osteotome technique to get some bone there. So this is kind of like my strategy. If I'm going to take the tooth out, and on the cone beam, I cone beam everybody. I don't use 2D, I just cone beam everybody. If I have less than 7 millimeters at the furcation, when I take that tooth out, I'm almost always going to bump up the furcation. And then when I come back, the implant goes in. And it's very easy that way. I don't have to worry about a lateral window and maybe some tethering or scarring, so that's what I do. So let me just show you a couple of cases as we go along. I'm going to be very clinical on this. When you here, you can see it's a maxillary right first molar. In America, we'd say number 3. I think in Europe, we would say it's a 1/6. Am I right? Something like, there you go, thank you. See, I got that right, good, thank you. So it's a molar, it's got plenty of bone, it's broken down. I'm not gonna tell you, why don't we do a root canal on it? Well, there wasn't enough ferrule, that's what I'm told. And I thought that's pretty good for an oral surgeon to know what the word ferrule meant, so I was pretty proud of myself. So what I do in every of these cases, you're gonna see this, is the first thing I do is I get the scan with a patient tracking array, or I'm gonna call it a clip. And then I work it up. I put it in. And you can see, if you look here, see that blue? That's the, let's see, why did that, all right, let me go back. So that blue rectangle is the virtual implant. And I size it, so it's a 5/8 by 10.5, let's say. I'm just using that as an example. And I'm going to put it right where it needs to be, because it's going to go where the restorative space needs to be. And I'm going to plan that, and I'm going to look at the bone, I'm going to go fine. And then I'm going to drill my holes. So I'm going to, on this case, I will make a sulcular incision, I'll use vertical release, I put a flap on the facial, take the tooth out. Typically I use a piezo surgery with a periotome type tips. Sometimes I use a drill. I don't use all that other fancy stuff. I don't drill through the tooth and then take the roots out. I don't have enough time to do that, so I don't do that. I don't use the socket shield. I just don't. That's just me. But you can do it. That's fine. I remove the tooth. I use the X-nav. I'm telling you which one I use. You can use whatever one you want. And then I use the Osseodensification burs to finish up the site. And the reason I'm doing that is based on my work, the stuff I've seen in the mandible, and just my belief in this now. So this is number 19 to be removed, which is the lower left first molar for our European colleagues. And again, I put the patient tracking array, I get the cone beam, I put the rectangle in, I know where the implant has to go, and it's right in the furcation. Well, surprise, right? That's where we do it. How are you going to drill that hole? So I used to do this with just the burrs that rotate clockwise, and I'd just remove all that bone. I'd collect the bone and put it back, but I would ablate it. So now I want you to carefully look from the series from left to right. In the first picture to your left is the furcation, it's the septal bone. It's pretty thin. I take a round burr and I make a hole, and then I use a pilot burr, and then I use the Versah drills, and I go through the whole series. I don't skip them. I go through the whole series, and I drill in and I come out, I drill in, come out, drill, and I'm bending the bone. If you look over here, you see that bone is bent. And if you look over here, you see it's bent more. And then you hear here, it looks like it's gone, doesn't it? But it's not. It's there. But I've bent the bone. When I look at the drills, there's no bone in the drills. No bone. It's all there. That's easy. That's easy. And then what have I done for the patient? I've made that position. I put the implant in, and I tell you, these implants do torque at 50 Newton centimeters, and then I crank them down. I wrench them down in there. So the primary stability is great. What you're seeing here on the screen, the video, is you're seeing the actual X-nav in use. And you're seeing that dot. You see, so this is the first drill I'm going to use. I'm going to put it right where it's supposed to go. And I'm still the drill. I am still in control. You still have to drill a hole. You have to be in control. So I am controlling where I'm drilling. I use a round burr. I use a spiky burr, the ones that are kind of like a spike. I use a Lindemann burr. I don't care what I need to use as long as I get in the right spot. And then I'll use the pilot drill, and then I'm going to go through the sequence with the Versah drills. And the Versah drills, sometimes when you first use them, they'll just drop right down. You go, well, all right. And you look down, yep, I'm in the same spot, and I'm still in the right spot, and I just keep on increasing the size. I don't know if I'm doing it right, but apparently it works. So what I mean by that is I'm going through every drill along the sequence. And I do that because I just want a little small increment at a time. I'm trying very carefully not to damage the bone. I'm trying to be very, very, very sacred with it. So I just keep on drilling, and you can see I'm just going through the sequence, and I'm right in the middle, so the implant should go in the right spot, right? So I don't know how many of you have tried to put implants in the immediate molar sites, but sometimes they're not so easy. They seem, but if this system with the navigation, it gives me that little extra belts and suspenders. And to do this. So I kind of like doing it that way. And then when I get the implant in, I look at the x-ray. I cone beam everybody after I do the surgery, just to make sure. Why do I do that? Because, before I was doing navigation, 2 or 3 times a year, I'd have to go back and replace the implant because I was off, believe it or not. I mean, does that ever happen to anybody else in this room? Of course not, right? So I'm just a country doctor, so I check. But I look at the plan and look where I put it. It's pretty close. And then so now when I'm doing that molar, remember I took out that molar? I'm going to do the same thing. I follow the same path. But what I want you to see is the flowering of the bone you get from the burs. Now, that's really important. Now, when you put the implant in and you put your healing abutment on there, you got to make sure that you don't have a little bony interference so the healing abutment seats. So you might want to take a little scalpel and just wipe that off if you need to, just to seat everything. And then once I get that in place, I graft the extraction sites. I put some allograft in and then sew it up. That's what I do. So I use these for immediate molars all the time. I mean, all the time. Now, if I'm taking out a tooth, like this tooth that you see to your left, what I'm going to do is I'm going to pop the furcation up. And when I'm doing that, I'm going to pretty much flatten the bone. Now you see the bone is there from the buccal and the palatal roots, but in between is where it dips down. So now I got it flat. It's 12 millimeters. I should be able to drill that hole and put the implant in without even giving it a second thought. Now you see those roots on that to your left? You see how close they are to the sinus floor? I find that's where I perf if I do a lateral window because of the tethering. That's just me. So now I plan it. Now this is interesting. When I do the furcation, remember I've cut between the distal and buccal, the buccal roots, and then from the buccal roots into the palatal root, and then take that little and then pop it up. And sometimes when I look at the scan, I'm seeing this sort of bone that looks like this. See that right there? So I'm thinking, do you ever think how I'm going to screw this up and how not to screw it up? So I'm looking at it going like, if I use a burr that rotates clockwise, I will ablate and remove all that bone graft that I've created, won't I? So now I'm just going to use the Versah drill. So I drill up with the pallet drill, do the rest of them with the Versah drills, and I expand it. And then you go from that to this. Now to me that's huge because now I've got the implant in bone. It's dense, it's compacted, and it's in the right spot. And I haven't lost the graft that we were so delicately doing. So I'm using these all the time for this kind of approach. And this is just a video of that. Now, this is an older case, you could tell by the software. Now their software has nice colors on it and stuff like that. You can see my bald head in there. I'm looking at the screen when I'm drilling the hole. It's a different attitude. It's a different approach. You really don't look at the patient too much. Yeah, a little bit. I mean, you do, but you're really focusing more on this. So I put the implant in. And again, you can see I'm going from the left to the right. I like these burrs for this approach. I think they're useful. I'm not sure if I could do this as well with the conventional burrs. So I'm combining this, and here you see, a year post restored, good bone density, and I just, that's what I do. So it's easy. I didn't use the LPRF on that case. I didn't make the bones that way, but it's okay. Now, how about this case? So the maxillary right second molar, number 2 or number 1-2, depending on where you are. So that to me, that's a case that I can take the tooth out and graft it, but I really don't have a lot of bone there, do I? So I'm thinking, all right, that's easy. I can just take it out and I'll cut the furcation and pop it up and come back and do the implant. So that's what I did. So you see on that, it says I think I got 9.9 millimeters of bone, which is not bad. So I have taken this case and all of a sudden made it into a very, very simple implant placement procedure. And now the interesting part is when you move the furcation up, which I think is a great procedure, simple, you got to be delicate, it's a little technique in it, but not that much. I mean, if you're gentle, you're good. If you're kind of if you have heavy hands and you can't be gentle, you shouldn't be doing this. But most of you have nice, gentle hands, and you always tap your own tapper, right? Remember that. So, but you see here, this is another one where the furcation's up, and if I use a drill that goes clockwise, I'm going to remove all that bone. So this is where the Versah drills come in. And then I just go ahead and put the implant in, and I drill to a millimeter below it. I take the osteotomes, tap, Versah drills to finish it up, and I'm ready to go, and you can see the post-op. It's just like this every time. And I was surprised, 44% of my maxillary molar implants have sinus elevations at the same time. And I think that was an interesting number. Now, sometimes when you do the furcation intrusion, that furcation will turn or twist a little bit. And you sometimes get these x-rays that look sort of interesting. I mean, the first thing you would tell me is, I left a root tip in there. I didn't, but I thought I might have, but I didn't. It was the furcation. And you get these and you let them heal, and then you come back and you see it smooths out, and you get this healing up, and then you're ready to go. You can put the implant in. So, and when I'm putting the implant in on these cases, almost every one of these cases, I'm thinking if I use a drill that's 10.5 millimeters, 11 millimeters, or whatever I'm putting in, and it's going to remove bone, I'm not going to have a successful case. I'm going to have some bone loss. So I just use the Versah drills. I drill right up with the pilot drill. I put the next one in, and I go in reverse. And I just sit there with the navigation system, and I just do my thing. And it works. And here you see, here's a couple years restored. So the bone levels are very solid when you do this. And I do think it's this. Another one. So I didn't want you to think I just do one case and show you a nice, pretty case. I'm going to show you a whole bunch. Any questions so far? You good? All right, number 14, maxillary left first molar. All right, so I look at this case, and I can't be the only person that has patients coming in with broken down molars that have had root canals and have osteolysis, right? So you would look at that case and you go, what am I going to do? I'm going to take it out, but notice I got some bone loss on the buccal and a little, not really too much on the palatal, mostly buccal. I'm going to take the tooth out. I'm going to do the furcation. So, I'm sorry, on this case, I took it out and just grafted the socket. Now, I come back, this is 3 months, and I'm looking at the scan and going, all right, I think this is a hard lateral window to do because of that septi. That's what I'm looking at. I'm thinking hard lateral window. And I'm looking at the crest, and as you can see over here, you can see that little buccal defect there. Soft bone, there's bone there, but it's soft. So how am I going to approach this case? So I want you to think you're now being the surgeon operating on this patient. How are you going to put the implant in and have good bone up there and not have a perforation and all these kind of things? So I went to Dan Cullum's course, which is great. I mean, I participated in it. And if you want to do a sinus elevation course from the crest, that's the course I would go to. But here, I'm going to drill with the regular drills to about 4 millimeters in diameter, in that range. And I'm going to use the navigation system so I go right to the right spot. And then I'm going to osteotome it up just to break the floor. And then I'm going to finish the whole prep with the Versah drills all the way up to the 4555 drill. Now, the 4555 drill is what I like to finish with when I'm putting a 5.7 implant in, a 5.8 implant. That's just what I like to do. And I think Sala would be happy with me that I know those numbers, right? You didn't think I knew that, huh? All right. And then I do put xenograft in there. I use a low temperature dried xenograft, which means it's going to resorb over time. I put that up into that spot and put the implant in. That's what I do. So that's my sequence of thought. I don't give this a second thought anymore. This is just routine in my practice. So I don't get, my heart rate doesn't go up. I don't get worried about it. I say, no problem, we got you covered. So now what I'm doing here on the navigation is I made my incisions, reflected the tissue, and now this is my pilot, this is my round burr. Or you could use a spiky burr, whatever you want to do. And then once you get that one hole made right in the middle, everything fits in that hole, and you almost don't have to look. You just concentrate on this. Now, if you look on the middle part of this screen, which is right here, you see that? I want you to be focusing on that really more than the other part, because you're going to see where I'm drilling to, right to the floor of that curved part of the sinus. Without navigation, I don't know how I would do this. And without the Versah drills, I don't know how I would do this. So to me, the combination of the two. Now, once I get to the right diameter, then I go to the osteotomes, and I use the flat osteotomes, not the ones with the dome. And they're tapered a little bit. I got the old Summers. And I just go tap, 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 and I break the bone because I've gotten almost to the floor, and I just pop it up a little bit, not a lot, just a little. And then I take the Versah drills, and I finish it up to depth. That's what I'm doing. So as you're seeing me do this drilling, you'll see that I'm going to be doing, that's what I'm doing. And then I bring it up to the depth. Now, we stopped running, so I guess I go to the next slide. Now, and then I put the graft in. I've got the Versah drills finished. I put the graft in, tap it up with the osteotomes, put the implant in, and I got a lot of bone in there now, don't I? So this is easy. So these are the cases that I like to do, and I'm doing this routine. So you can see, though, on the plan to your right and the actual to your left. And these cases, they just heal up like a champ. They do great. I don't know how I would do this otherwise. Now, this case here, 5.2 millimeters in the furcation, which is the maxillary left first molar, otherwise known as 14. Now, what I'm going to do, I'm going to take the tooth out. So I take it out, and I pop up the furcation. Now, as you do these, some of these cases go real smooth, and you think everything is good, and you take the x-ray, and I go, huh. Now, I didn't perforate the membrane, but it's up there, and I'm looking at it going like, well, let's see how this heals. Do you ever do that? You ever look at skin and say, well, I'm going to see how this heals, but I have a belief in the process, and then this is how it healed. So, and this is an elderly person. So 8.8, an elderly means older than I am. That's so you know that, all right? So 8.7 millimeters. You see the good density of bone. I put xenograft up high, allograft in the crest. That's typically what I do. So I do some xenograft, a low temperature xenograft, which is going to resorb over time. Now, I look at the cross sections. Again, now this is your patient. You're choosing when you look at see, if you don't look at these scans, you don't even think about this, do you? You don't even think about this. So you're just going to drill a hole. Well, no, you got to look at the cross sections and the sagittal views. And you say, if I use a drill that goes clockwise to a blade, I'm going to remove all that bone. But I've done all this work, so it's just the Versah. I just take the Versah drills. I have my kits. I tell them, give me the Versah kit, and it's already set up, and I just drill a couple holes with the other kit just to get started. I take the Versah drills and just continue. I can do the whole thing with the Versah kit, without a doubt. But, and I don't use the finishing burr on the implant kit in reverse. I don't do that. I once did that, and then I talked to our friend, and he told me, don't ever do that again. That's what you told me. So I listened. So now I'm drilling my holes. Now again, I'm going to go right. If you look at the sagittal cut up there on the top right, on the top in the middle, you can see I can see exactly where I'm going. And as long as your patient tracking array is accurate and it's in the right place and you calibrated right, that's within 0.5 millimeter. So you go and you just feel it, and then it sets a little line on that circle. On that yellow part, it sets a line, and that's your depth. Then from there, you just drill up to that depth, and you're all set. So I do that, and you see it's just every time, every day, all day long. So that's what I wanted to show you. I wanted to show you these kind of things that just set you up for success. And then once I get the right diameter, tap, tap, tap with the osteotome, that's what I do. That's what I do. There's a lot of ways of doing that. This is what I do. And I tap it up, put a little graft in there, and I'm ready to go. Now what I'm doing, if I only have to go 2 millimeters, I drill a hole, tap, 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 finish it with the Versah drills, and don't even put a graft in. So I'm gradually learning to use the system a little more aggressively. So here's here it is. So you can, again, I think that to me, that's a great x-ray from where we started. You can see the bone on the apical side, and it's going to heal up just fine. Now, on some of these cases that we see, there's a 58-year-old female, fractured number 3, which is the maxillary right first molar, and I'm going to take it out, raise the furcation, and then superiorly reposition the furcation and put the graft in there. But you look at that osteolysis and say, oh, you shouldn't do that. Well, I do, and it works fine. Remember, you take the tooth out, you don't have osteomyelitis, you just have a local infection. And you got to be careful. I mean, Dr. Charvet sent me this case, so I went ahead and did it. And now, sometimes when you tap it up, you tap it up, you give it a little tap, 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 and it just kind of like goes up pretty high. And you look up there in the wound, and you go, wonder where that went. So now I'm saying that, and I don't mean to be sarcastic about it, but if you read Jensen's original article on it, he will say that he did the osteotome and tap, 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 and sometimes he didn't know where the furcation went. He said it kind of disappeared from view, but normally it lays somewhere in there. And I thought it was interesting that he actually wrote that. So this is what you see. Now, it's not a perforation, it's just moving everything up, but sometimes you don't get the elevation on the sides. Remember, these are bad teeth, and you got tethering of the membrane. So anyway, this is I put the implant in. I just drilled the hole and put the implant in. I used the Versah drills, and I mean, that little spiky part, I don't think there's anything wrong with that, so it's going to remodel over the years, and it'll be fine. Now, you get these cases like this. This is a maxillary left first molar that we're going to take out, and look at the osteolysis on that root. You see there's a lot of palatal loss here, isn't there? And you see this all the time, so I'm not going to be concerned about it. I went ahead and took the tooth out and grafted the sockets with allograft. That's what I use, and I just use cortical cancellous, whatever they give me. I don't think it makes a difference in my particular hands, so I just use whatever they give me. And then I drill the hole to within 1 millimeter of the floor, osteotomes to 11, finish it with the Versah, and I didn't use a graft. I just put it in, and that's what you see. So that's drilling to just below the floor, tapping it up, and then finishing the site with the Versah drills, and then putting the implant in. So I'm telling you, now 2 millimeters up, I go ahead. Now, I know you said 3, but I go 2. I mean, I don't know. Maybe I go 3. It looks like 2. When I was working with Jerry she would say, I want you to put the implant 2 3/4 millimeters apical to the finish line. And I look at him and say, okay. My resident would look at me, how can you do that? I said, well, just set the caliber. It's easy. And they believed me. So, what can I tell you? Now, very interestingly, there's very strong literature that you don't need grafting material many times. If you just raise the sinus membrane and hold it elevated, you will get a very reasonable amount of bone. And I happen to be an editor on our journal, and I see all these articles coming through. That in general, this works. It works really well, but it's not 100%, maybe 80%. So 20% of these cases don't work. So I'm still grafting these cases, but some of the results they have are phenomenal. The other thing I wanted to point out to you, and this is a very interesting article by Spinato in 2015. They saw, and they have good evidence base, that if the sinus has a relatively narrow profile, not a big, broad, flat profile, it's very good for crestal approach. So the more the sinus has a definitive The lateral nasal wall and the lateral part of the maxilla, it's definitely a U. It's going to work. If it's a flat, it may not work as well. So just be aware of that. So, sites, now this is an interesting case. An ophthalmologist I've known for years, I'm going to put the implant in 11 and then he fractured 13. So we're going to put an implant in 11 and 13. Now, that immediate premolar is not that easy to do because it's a hole. And actually, I want the implant to be on the medial side of that, and I want it to be well defined. And I don't want to take a lot of bone off. So I said, all right, this is easy. So what I'm going to do, I'm just really showing you the premolar because the canine's easy. Drill a hole, put it in. But so this one's a little more difficult because you can see where my virtual implant is on the medial side of that tooth. And those premolar teeth look bigger in reality than on the x-ray. I mean, at least they do in my hands. I wear loops, so they look bigger. So now what I'm going to do, I'm going to take the tooth out and I'm going to do the whole thing with the Versah drills. And you can see, this is in the 13 side, the premolar side. Again, I've got everything planned. I'm navigating the incision. I'm navigating the osteotomy. But as you're looking at the part on the left part of the screen, just put your eyeballs over on that right side. And this is the phenomena that you saw earlier today where that bone kind of flowers out and you get a very dense osteotomy created for your implant. So when you do this, all of a sudden I can put that premolar implant in, torques out at 50 Newton centimeters. I have to crank it down a little bit. I'm all set and it's in place. So this, and you can see I'm drilling. You see I'm drilling right up to where I need to be, but it's in reverse. You see when the pulsating part on that yellow part, that's in reverse, and I'm pulsating it a little bit. So I'm clearing out some of the debris or some of the water, just getting some water in there so I'm gentle. I set the drill at 800 RPMs in reverse, but I don't press the pedal down all the way. So I'm probably in the 300 or 400 RPM range, but I'm using every sequence of drills. I don't know if I did that right, but I think it's working. But look at the flowering of the bone. Get good dense bone. All right, so let me keep rolling. So here are the implants in position, and they're perfectly positioned, of course. Anatomical shaped abutments. I get them stock, so I put them in. They're nice. Now, the other part on this is these patients come in with porous bone. So this is a woman, she has osteopenia, not really osteoporosis. She's not on any bisphosphonates or anything like that. She gets prolia, but that's about it. And I took out number 19, which is the lower left first molar, and grafted the socket. And I come back 4 months later, and I'm seeing this x-ray. So to me, that's not good dense bone, but it's soft bone. Well, I don't worry about it now. So I'm going to, in a soft bone situation, I grabbed the Versah drills. I said, get them out. And I've got my plan, and I got the plan all set. Remember, I XNav everybody. Everyone gets navigation. If they walk and talk, they get it. I mean, that's what I do. But as I'm drilling this hole, as you can see here, notice on the right side a picture of that site. This was very porous bone. I mean, you could take the drill in the beginning, just drop it in almost. You ever see patients like that? And as you go through the sequence with the counterclockwise rotation, and you do it carefully, you get this very dense bone all of a sudden. And then when you put your implants in, on this patient, she torqued out at 50 Newton centimeters. I had to wrench it in another millimeter. So I see this kind of approach, and I'm all set. Now, if I find that I need to adjust with the XNav or the dynamic, I'd go ahead and adjust it. It's really simple to do that. So I do it online. So that's why I like these drills rather than a static guide. A static guide. Now, I know some people are printing their own guides. Hey, knock your socks off. It's not for me. I don't have the time for it. All right? I don't want to order static guides for everybody. I do this. It takes me 5 minutes, 10 minutes to program this, and I'm ready to go. So I try to be efficient. And a lot of printed guides are not accurate enough. They don't have the same metallic sleeves and all that. So I do it this way. So it just works really easy. And the implant goes in, and you're all set. I mean, it's patients, no pain. Their pain levels are very low. Ibuprofen is all they need. I'm not a big narcotic person. This guy comes in. He's a CEO of a fairly good company in New Orleans. And I see a lot of CEO-type people, executives who just don't take care of their own teeth. They're just too busy. And, he owns a couple bars and all that. So he's a good guy. And so he comes in that upper left quadrant. It's a problem. And I just want to show you, this is so routine in my practice now. The canine, 2 premolars, and molar have to go. So, the 2 premolars and the aponic area and the second molar have to go. And you can see there's not a lot of bone in some of these areas, so I'm going to take everything out and graft it. So what I'm going to do, though, is let me go back here. I just wanted you to see this one little particular spot right there. See that The lower one, it's got 1 millimeter bone. I'm going to do a crestal window. My crestal windows are different than the one you saw. I take the piezo and I cut a rectangle. And then with the bone intact, I tap that up and it goes up. I don't ablate that whole crest. My window is like the old lateral window that you do where you just make the outline and the bone goes up. So I do that. I preserve that bone. Tap it up and put the bone in there. That's what I did on this case. So you can see that on your left side, I've made the incision around the next of the teeth, crestal incision around the next of that second molar, which doesn't have any soft tissue on it. Maybe I should use the LP or F there, I don't know. But so I went ahead and did the crestal window and grafted the sites. But this is what I wanted to show you, is that this becomes so routine now. After he healed, this is about 3.5 months, you can see that I have, in some areas, I have what? I have bone to the implant. Then other areas I have 9 or 7, 8 millimeters. These are easy. I don't even blink. I don't even blink an eye on this case. I know I plan it out. So I've got my plan, and if you notice over here, you'll see that indeed, let me see if I can get this to work. There we go. See that? That's a pop-up, right? That's a pop-up. See, I mean, you see, you can see the crestal window was the one with that kind of like spiky thing coming up there, that little protuberance inside the sinus. That's where I use these burs. So I drill a hole, put the first implant in, no problem. The second one, go to the floor, tap it up, put the implant in. Next one, the same thing with the Versah, tap it up, put it in. And I don't even blink an eye. This is this is routine, and there you see it in place. So this guy started with a fairly bad scenario in his mouth, and he's all set. 2 surgeries, that's it. One to take it out and graft everything, second to put the implants in. So it's very simple surgery. And again, I don't know if I could do this surgery as well with regular burs. That's the kicker on this whole thing. So you get people like this who come in and they don't have a whole lot of bone. I mean, on this woman, what you're seeing that 4 millimeter one is actually the ponic site over here, which is that premolar, and then you'll see the other site is on the other side, about 4 millimeters. So I did crestal windows on both sides, put the grafts in place, and you can see how the grafts are healing. I mean, they healed up fine. And then you go ahead, and you'll see some settling with this. I've got 13 millimeters of bone there now. Well, I can put a 12 millimeter implant in there all day long and not have any problems. So this is where, but in the cross sections, it looks like this. You see how the cross sections are so intriguing, or the sagittal section. You're seeing this just the intrusion of the furcation, and you're seeing that bone up there. So if I use an ablative drill, a drill that goes clockwise, I remove all that bone. Now, I don't want to do that, so I use the Versah drills. So, when you have where do I use them, how many times have I said the same thing, and you see the results? I mean, it expands and contracts and compacts the bone, and I just think it's totally changed. When you're looking at this case, this is a 83-year-old. The lower implants are 25 years. 25 years. This was with a guy who used to work with Dr. Charvet that I started out with him, and then she comes in. And you see, I'm going to take out the premolar, and she's got the sinus. So we're going to do the same thing. Anyway, so now you see, so I did the crestal window and popped it up. And again, you see the same thing. So I do this all the time. All the time. It's so easy to pop that crestal window up. You get what you get, and then you go ahead, you do the plan. I always like to plan it. You're going to notice that I have virtual teeth in there. Sometimes I scan the case with an opposing arch, put everything in, make sure I'm going to put it right where it's supposed to go. And if there's no bone where it's supposed to go, if there's bone that's going to be removed, I'd expand it and move it around. And that's what I do on her. So I did the same thing here. Go put the drills, expand it, tap, and put the implant in. So I'm getting these results all the time. It's just all the time. So, and I know I'm going to stop early, and I'm doing that for a reason. I'm going to ask you to ask me questions because I have to go catch a plane. But because I'm talking to the California Oral Surgery Society tomorrow, so I got to get there. So, why do I use these? So if I'm going to summarize why do I use these burs, I'm going to compact porous bone. That's one of the first reasons. It just does it. It really works. I'm going to bend and shape the bone without its removal. Key, very key in my practice. Because now I just do all these things and I don't even blink an eye. I don't like using short little implants in the maxilla. I just don't like that. I can finalize the sinus graft sites, shapes the implant site for immediate molars, as I've shown you, and I don't remove interdental bone. So on that, I'm going to stop, and then I'd like the lights up, and then we could have some questions. Question over here, sir. Sure.
And the second question is, isn't there going to be jagged bone in the intrusification?
All right, so let me talk about how I do the intrusion on the furcation. That was the main question, and I think I'll address your second question when I do that. So I make an incision, flap the tissue, and I take the tooth out. So now I have the mesial buccal root, good, distal buccal root, palatal root. In between is the bone, the furcation bone. I take the piezosurgery drill. It's got the serrated tips, and Monica, she has it over there. You can go see it, and she knows which tip I use. But I take that and I cut in between those roots through the floor of the sinus, carefully. What does carefully mean? I'm having a Zen moment. You just feel the loss and you stop. Then you turn it and do the other one, and then you do the other one. Now the furcation should be relatively mobile. I take a flat osteotome and I go tap, 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 and it just goes up. And I very gently tap it up. I don't go bang, bang. I go tap, tap, tap. And tap, 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 tap. And I'm saying that not sarcastically, but sincere. You have to be gentle. If it doesn't move right away, I go check my cuts. And when I take it up to where it's going to give me, it gives me 6 millimeters. That's all I take. Do I put an instrument in there and try to move the membrane? Absolutely not. I'm not that good. No, I don't do that. So I take what it gives me. That's why I got these things sticking up.
And then you have the furcation mobilized.
They have the furcation mobilized and it's up high. And then I put xenograft up there and I put allograft in the socket, the rest of the socket, and close it up.
Okay, so you come back later and place the implant.
Yeah, I put the implant in secondarily. Yeah, I don't put the implant at the same time. No, I don't do that. I'm not that gutsy.
So you're doing like basically
I do 2 sequential procedures. I don't put people's names on a procedure. I just tell you what the procedure is. Yeah, thank you for your question. Question? Yes, sir. Loud.
It sounds like you really believe in the dental, but why do you still use an osteotome?
Why do I use an osteotome and not just use the Versah drills? Maybe it's just my background. Maybe it's just what I normally do. I'm very comfortable going to within a millimeter of the floor and tapping it up. I'm very comfortable doing that surgically. I'm not that comfortable thinking that I can take the floor off and have the membrane sitting there and not damage the membrane. Now, I know that these burs are not supposed to cut the membrane. You've seen all kinds of, that's good. I believe them. I'm going to be more conservative. And I want that bone to go up with it because it takes the membrane up with it. So that's just my training. That's where I come from on these.
The fact that you do it as guided surgeries now too, you can even see on the thing how close you're coming.
Yeah, so your comment on the guided, I can see how close I'm coming to. That's correct, within a 0.5 millimeter of accuracy. So there's still a little inaccuracy with that. Not much, just a little. But I go to within a millimeter, 0.5 millimeter, and I just tap it up, and it just taps right up. It's so easy. And then I have bone there, which takes the membrane up with it. And I've had great success with that. I know you see a lot of people that propose that they take that, they drill up and always expose the membrane, and then they put an instrument in there, or they put a balloon in and do all. That's fine. They could do that all they want. I don't do that. I'm doing it. I'm showing you the way I do it because I know it works hundreds of times in a row. So, and I'm not meaning to say that if you want to expose the membrane all the time, go for it. But I personally am not that good. So I will leave that bone in there and tap it up. And then the membrane comes up with the bone. Less chance for perforation. That's the reason. Great questions. Thank you. Question in the back. Anybody in the back? Who's going to win on Sunday? The Saints. There you go. Perfect. Anybody else have a question? No? Well, again, I want to thank you again for the invitation. I hope you enjoyed it. Thank you.